25-year-old male comes to ER with abdominal pain and develops seizures. Dr. Patrick examines the patient and finds that he is generalized tonic-clonic in nature. He administers injection midazolam, 0.2 mg per kg intravenously. Alternatively, injection lorazepam, 0.1 mg per kg IV, or clonazepam, 0.015 mg per kg IV can be given. Seizure stops. History reveals that the patient came to ER 2 hours back with abdominal pain. The patient was treated initially for intestinal colic. No other history is available as the patient speaks only Japanese. General examination is normal, vitals are stable, patient is still in postictal confusion. Systemic examination is within normal limits. Dr. Patrick orders CBC, serum glucose, liver function test, renal function test, thyroid function test, USG abdomen, serum sodium, serum potassium, serum calcium, serum magnesium, CT scan of the brain, lumbar puncture, ABG, tox screen, Immediately, another episode of seizure starts. Injection phenytoin, also known as Dilantin, intravenously. Alternatively, injection levetiracetam 20 to 30 mg per kg IV, or injection sodium valproate 20 to 30 mg per kg IV can be given. The seizure is continuing. The patient starts to desaturate. Now it's more than half an hour after continuous seizures. This can now be called as early refractory status epilepticus. The patient is intubated and put on mechanical ventilation. Injection midazolam infusion started as 0.2 to 0.6 mg per kg per hour. Alternatively, propofol infusion 2 mg per kg per hour IV can be given. It turns out that the patient came to visit his aunt from Japan. He was staying with his aunt for the past 1 week. His aunt tells him that the patient has a history of occasional abdominal pain, sometimes associated with headache, since childhood. Each episode lasts for 2 hours. Dr. Patrick is not able to get any other significant medical history. Since all the investigations come to be normal, Dr. Patrick takes a wild guess of acute porphyria. Dr. Susan is of the opinion that since the family history is negative and the USG abdomen is normal, the diagnosis is unlikely. So they decide to test the urine for copper porphyrinogen and faces for porphyrins. The results come as negative, so they decide to wait for the EEG after the seizure subsides. Seizure finally subsides after 2 hours. EEG done. Now, Dr. Patrick surmises the diagnosis to the patient's aunt. Please pause the video and find your provisional diagnosis. The patient has a history of multiple episodes of abdominal pain with headache since childhood. The EEG shows a spike and wave pattern in the temporal region. The consistent history of abdominal pain with headache with the EEG findings in the temporal region is suggestive of abdominal epilepsy. Dr. Patrick suggests tab sodium valproate as treatment. The diagnosis of seizure disorder is a tricky business, but the initial emergency management is the same for all.
This is Dr. George, and thanks for watching.